Presentation, please. Good evening. Today I will share an experience with a new lens we have been using for a while in Samaya Eye Center with very satisfactory results. I'd like to share this with you. This disclaimer, and this is my financial disclosure. So if we think about how the cataract surgery are right now, we are required as a cataract surgeon, this exactly describe how we feel nowadays in cataract surgery. So we are supposed to improve the distance vision of our patients, improve the night vision, correct the astigmatism, and also correct the presbyopia. This is how we feel right now. And so simply we need an ideal IOL. I go with this definition of IOL by Dr. Reza et al. This is IOL which restore the patient vision without complications or visual compromises and allow the patient to regain his or her ability to see at all distances. Definitely, this just describes the crystalline lens of a healthy immature 18 years old. This we don't have this still as a manufacturer lens. We have still some unmet needs. This include the presbyopia correcting lens. Still, we started with a trifocal. We tried the accommodating lens, and then we went back to monofocal plus. We tried the monovision, and now we are landing on the EDOF lenses. The current patient challenges still, our patients usually are not happy with the halos and glare coming from the trifocal and multifocal. And we still trying to minimize the dysphotopsia coming from these kind of lenses. The good thing about this lens, it's coming on top of the thickness platform heritage. We're already so familiar with the thickness platform. We're using a lot of monofocal and monofocal plus lenses in the past few years. We know how these lenses do in a stable way. We like how the A constant is stable for all the equations. We like the tolerance for a refractive error even, and even the focus on these lenses. So this is the new lens thickness Pure C. And simply it adopts a new technology. It's called the OptiCurve, purely refractive EDOF technology. We're all aware that the difference between refractive and diffractive, because in refractive lens is a continuous, smooth change in the power of the lens, either anterior surface and posterior surface of the lens. In diffractive lenses, there is some sort of rings or elevation on the anterior surface or posterior surface of the eye. We expect more control and better vision for all distances in diffractive lenses, but on cost of dysphotopsia, halos, and all other unwanted visual symptoms of the patients. So with this lens, we have this anterior optic and posterior optic. So the anterior optic is exactly like the eye hands. If you are familiar with the eye hands, it is the same anterior optic design of this lens. The new thing about this lens is the posterior optic. It's a posterior optic refractive surface with a continuous change in the power, enable consistent depth of focus, and provide tolerance in a small refractive error even. This is the focus level. If you think this curve, it's giving exactly comparable results with monofocal lens. So it definitely is superior to the other multifocal lens. And if we have this portfolio of productions of Johnson & Johnson lenses, we can see that it's a matter of compromise. So you have a lens looking for correcting all distances. So you are putting this lens in the high risk of visual symptoms not wanted by the patient. So on top of that, like lens like Synergy, even Symphony, you have different distances. You have distance, intermediate, and near, but still this patient will complain from some sort of halos and dysphotopsia. On bottom of that, the thickness eye hands IOL, the monofocal, we have excellent distance vision. We have some intermediate vision, but we don't have enough what we call a functional intermediate and near vision. And this is why the Pure C coming to fulfill this gap. So simply the idea is this extending the depth of focus while maintaining a low level of visual symptoms comparable to the monofocal IOL. This is what we're looking for. The point also coming is two things about this lens. It's all shared on other lenses from Johnson & Johnson. So it corrects the chromatic aberration and correct also the spherical aberration. How this works, we're all aware of the spherical aberration. The point is we have the rays from the periphery has more deflections than the rays from the center. So in a patient with a wider pupil, we expect some sort of myopic shifts. This is spherical aberration. So it's mainly or less more independent on the size of the pupil. The other thing is also that this will all affect to the contrast. If we think about the chromatic aberration, the chromatic aberration mainly is concerned with what you call the ab number. So the ab number, the higher the ab number, the less dispersion of the light through material, because this is reflecting both the refractive index and the nature of the material. We know that the highest ab number in the nature, the glass, the crown glass, is about 58. This is the best one. So there's no dispersion from this kind of lens. And with all Johnson & Johnson IOL, the ab number is 55. This is still too high for an IOL. It would be the highest ab number for an IOL. So it gives definitely less dispersion. If you think about that comparison to other lenses, and we have the highest number from other manufacturers, about 38. This is definitely a significant difference between this. So the chromatic aberration, also correction in this kind of lens and platform, we have definitely better quality of vision than simply reducing that. This is also some sort of imitated image distribution coming from the thickness one-piece IOL, thickness pure C IOL, and thickness multifocal IOL. You can just monitor here how the thickness pure C IOL giving very continuous and smooth power change all over coming from the anterior and posterior surface of this lens. And this is going to be reflected on the daily life, so the patient can enjoy uncompromised near vision, intermediate vision, and distant vision without any loss of contrast. This will be very useful if you have a patient with other problems like anterior corneal disorder, patient with unstable tear film, patient with glaucoma. So all patients those cannot tolerate any difference and any compromise in the contrast. If you see also this optical bench testing, so we can see the halos definitely for the pure C is almost equal to the thickness one-piece IOL, the monofocal one. And you can see this the halos definitely annoying with the thickness symphony optically. Again, this is giant difference just between the refractive EDOF lenses, avoid the concentric ring, and the visual quality impact. So refractive lens maintain high image clarity while reducing halos and glare, and this definitely with the approved clinical benefits. So you see this is performance of thickness pure CIOL provides a monofocal light quality vision comparable to the eye hands. So you will see this is the contrast sensitivity is not compromised in this type of lens. Compared also to other lenses manufactured by other pharmaceuticals companies, we can see this is definitely the MTF difference also much less with the pure C thickness than the other IOL. And with this also, this shows the less dependence of this lens on the pupil size. So regardless of pupil size, is it large or small, this lens will not be affected, and there's no myopic shift or myopic surprise by the end of the surgery. Again, this is a photic phenomena, which give also how this lens, and this is not just about the pure thickness, it's about all the thickness platform, that it tolerates some sort of refractive surprise. If you have a patient from plus 0.75 to minus 0.75 refractive surprise post cataract surgery, this lens still is forgiving for that kind of refractive surprise. The good thing about it, you can do it for metropia both eyes. You can go for mini monovision like minus 0.5, minus 0.75 in a non-dominant eye. And we can get a very high satisfaction results in a patient with almost 100% to 98% independence from glass. This is what I'm just explained, the resilience with maintained visual accuracy. So usually, this is the published data about that the patient can tolerate a refractive surprise between minus 0.5 and plus 0.5. In the daily practice, we already experience a lot of patients tolerating up to minus 0.75 to plus 0.75 even. This is a very useful clinical evidence data came from a study, what's called the post-market study. It included a large number of patients, 238, operated 476 eyes, included 17 sites across Europe, Asia, Pacific. And the study just was focusing on a single visit after 3 months from the surgery, and they look for the spectacle independence, photic phenomena, and patient satisfaction. These were the investigators. And if you look at here for distance, intermediate, and near, this comparison between binocular uncorrected and binocular distance corrected mean acuity. And you can see that in distance vision, this is almost like a monofocal IOL. Very useful intermediate vision, either corrected or uncorrected, and definitely this is what you call the usable near vision. So a monocular uncorrected visual acuity, most of the patient already achieved almost like 20/20, and with this corrected even surpassed these amounts. 87% of subjects achieve 20/20 vision or better, uncorrected binocular vision, and 94% of subjects achieved 20/20 vision or better with best corrected binocular distance vision. This is definitely remarkable results. And again, better distance corrected visual acuity was achieved by 100% of patients. So no compromise in the distance vision in any of the patients included in this study. For spectacle independence, the question was how much you use and the frequency of spectacle wear, none of the time, or a little of the time, some of the time, most of the time, all of the time. So what turned out that most of the patient was not at all, like 92% in patient was not using and the glasses. And for photic phenomena like glare and halos and some starburst, there was extremely satisfied patient on those patient implanted with the thickness pure C. Again here, of the patient satisfaction, most of the patients, like 96%, was completely satisfied with distance vision, 94% in intermediate, 73, like more than almost three quarters of patients were satisfied even with the near vision. So definitely for the outcome was 87% achieved 20/20 vision with 97% satisfaction. This is definitely a very high satisfaction rate for any EDOF lens. This is the patient I operated. This is posterior subcapsular cataract. So this is a patient used to have night glare and troubles while driving at night, and problem also in near vision. She's 55 years old female, diabetic but without any diabetic retinopathy. She has posterior subcapsular cataract, and the vision was uncorrected 2018, the left eye, and best corrected 2050 with severe night halos. The cataract was not dense, just a posterior subcapsular. So it was quite easy lens to be removed. This was under topical anesthesia. For the good thing about this lens is the implantation. It's very easy because simply it's preloaded. So if you are familiar with the preloaded IOL, it's exactly the same. Nothing fancy about it. Just very easy to implant. You need to enlarge the wound. Just very friendly lens, so simply just you inject it, and it will just have the same stability of the thickness platform with monofocal. Nothing change in the haptics or the design or the size or the margin of the lens. Really friendly lens to implant, and you can see here this is something red reflex. Giving a hint about the design of this lens. You have the central part of it with this continuous change in the power. I think this is the secret of the lens. This is how it works and give excellent intermediate and excellent near vision, even useful near vision. Actually, I was so interested the second day to see the patient. Fortunately, I was slightly dilated. I think this is the edge. This is not a circle. This is not a ring. It's just a smooth transition of the power of the posterior surface of the lens. Post-operative, the patient was extremely satisfied. This is a refraction, but anyway, she was 20/20 for distance. Uncorrected intermediate vision was also 20/20. And near vision was 20/25, and the patient was extremely, after 3 months of follow-up, the patient was no halos, no glare. She can drive her car at night without any troubles. And this is typical for this kind of lens, actually. It's not just about this patient. I was interested to go for, to do the power distribution and the internal RMS total value using eye trace for the lens. If you notice here on the top left, this is the internal high order aberration for this kind of lenses, almost zero on most of the values. All the RMS coming from the cornea, not from the lens itself. And this is comparison between real patient, this lens patient with the thickness pure C and the thickness eye has. This is quite impressive. If you see this, the depth of focus is 1.4 diopter in the thickness eye hands, and it's like 2.8 in the left eye and the pure C. And also the working distance, you know, the average of the effective range of focus of this patient is about 2.4. This gives me definite vision of intermediate vision up to like 30 centimeter. This is quite impressive for EDOF lens, not a trifocal. So this is definitely, you can compare between both the monofocal and this pure C lens. They definitely a remarkable difference in the depth of focus and the working distance also. In conclusion, my experience for this lens so far, this is definitely improved dysphotopsia profile and enable a consistent depth of focus with functional near and high quality distance vision and intermediate, and excellent tolerance to any refractive error within a range. And definitely the patient satisfaction is really remarkable about this lens. Here's my reference. Thank you. Any questions? Yeah.
I have a question. Thank you very much for your interesting lecture, but I would like to say that me and my team are the fans of the Johnson & Johnson's lenses, and during the last 5 years we use only this brand. But before we used the excellence, and we were satisfied, and our patients too. Then at first we started with Symphony, and distance was satisfied our patients and us also. Then came the iHands. It's more or less the same results gives. Now we have pure C. So now we have very big stock of these lenses. So my question, what do you recommend it to leave? One of them. I don't speak about the synergy. Synergy is a king of the multifocality. And what do you say? Which lenses we should continue? Because we have very few experience with pure C for today. And in near future, we hope they also bring us the Odyssey.
Odyssey.
Thank you.
Thank you. So this is a valuable question. So simply we cannot fit one lens for all patients. This is definitely not applicable, simply because every patient has different cornea, every patient has different retina, different optic disc, different axial length, different needs, different style of life. So simply it's not a matter of either choose one of them and just to stop implanting the other one. So, you know, if a patient have like still I think, still we are going more and more now to the EDOF lens. So the EDOF lens, like the pure C, I think, getting more momentum because simply you are giving better vision for patient in different distances without a compromise and without a photic phenomena like the halos and glare as starburst. Still, if a patient like a regular cornea and a patient with post-pterygium surgery, post-keratoconus, patient with abnormal or unstable tear film, patient with contrast problem, like in a glaucoma patient or retinal disease. So still I will go for monofocal plus lens like the patient eye has. If the patient have a pristine eyes, nothing wrong, perfect cornea, perfect optic disc, patient not are a professional driver, not professional pilot, I will go for the Symphony. Okay, so still I need the whole portfolio of lenses because I don't have a different kind of patients.
Yes, okay, thank you very much.
Yeah.
But I think I like so much this PRC.
Yes, it is
that
good.
I will discuss after some months when we have more material. We discuss and tell you what we decide, okay?
Sure. Thank you. Thank you. Thank you. Okay. Any other question? Okay. Hello. Okay, that concludes the symposium. Thank you all. Thank you for attending. Thank you.